got Linda Gail Bekker from the CEO of Cape Town. She's local, and she's going to talk about HIV.
Great.
Thanks,
thanks very much indeed. And thanks to the organizers for this opportunity. I come to you as an HIV doctor and preventer. So in the last 44 years, of course, 86 million people have been infected by this virus and 40 million have died. And we've known really from the very beginning that one of the transmission routes is via blood products or unclean syringes or syringe sharing. And so I was interested to see that the first syringe sharing program started all the way back in 1984 in the Netherlands. And it did in fact start as the 4H disease, homosexuals, hemophiliacs, heroin addicts, and Haitians. But of course, today, and particularly in this country, we know that it is the everyone disease. And, it is important for me as an HIV advocate to say that 1.3 million people acquired HIV in 2024, half of them amongst adolescent girls and young women in this part of the world, and the other half in what we term key populations. And in particular, 1 in every 10 HIV acquisitions occur in people who use and inject drugs. The 2025 goals of UNAIDS really put a whole lot more emphasis on primary prevention, and this is long overdue, with this call to arms that we were at a crossroads in 2024. And of course, everybody knows what happened in 2025 that really has brought us to the precipice as opposed to the crossroads. But even in 2024, although we had done well in treatment versus the 2025 targets for UNAIDS, prevention and issues like stigma and discrimination had really lagged far behind. So there are about 12.1 million men and 2.8 million women who inject drugs globally, of which 2.25 million who inject drugs are also living with HIV, about 27 times higher than the general population. And I do want to just draw attention to young people who are key populations, who really, particularly in this part of the world, are at huge risk for HIV acquisition. And again, just reminding you that a key population is somebody who is particularly vulnerable for HIV acquisition but cannot access services because of multiple reasons. So, of course, I'm sure you've all seen these graphs, these maps of where HIV and substance use disorder kind of collide as syndemics. And much of this is driven, and you've heard this time and time again, because of bad policies, ideology. Vulnerable people are deterred from accessing the services that they need. And almost all countries have punitive laws that criminalize at least one key population in one way or another. And almost all countries have issues in some way or form around drug use. Stigma has been a problem for the HIV epidemic really from the get-go, and it's a double whammy, if you like, when we talk about substance use disorder. Again, as we well know, women and people from sexual minorities particularly bearing the brunt of this. So as is often the case, this is more than just treating with biomedical interventions a disorder. But I am going to focus in on biomedical interventions. This is the international standards for the treatment of drug use disorders, but it's really the top 4, and I've included there pre-exposure prophylaxis, which has an impact on HIV co-infection in the setting of PWID. So I do want to underline that really we cannot think about HIV care, treatment, and prevention without also considering harm reduction. And of course, there is still a long way to go in making sure that harm reduction is prevalent across the world. And this is a slide I've used for many, many years to make the case around integrated care, Vancouver being sort of famous for this, of course. But important to note that, the reduction in HIV transmission in this city has not only been the impact of treatment, antiretroviral treatment, but very important also harm reduction. And of course, Vancouver now very famous for the efforts that have been made in rolling out good harm reduction. And of course, along with needle exchange programs, the importance of opioid substance substitution. And I'm pleased to say that like antiretroviral care, there is also now the option of choice for longer acting formulations, very, very important, and I'll obviously expand on that in a moment. This study, which I'm sure might have already been shown at the conference coming out of Kenya, again making a very important point that the way to improve antiretroviral uptake, persistence, and HIV outcomes is to integrate it fully with good substance use disorder management, and to make sure that we provide OAT as well as needle exchange programs and all of the social support in order to realize the miracle of HIV treatment. So we do know that treatment, of course, saves lives, it restores immunity and reduces opportunistic infections. In this part of the world, tuberculosis being one of the very important ones. And we also know that outcomes amongst people who use and inject drugs when it comes to HIV infection are lag behind other populations. And one of the causes for increased mortality, of course, tuberculosis, which we also see increased in populations of people who use and inject drugs. The prevalence of people presenting late with HIV is also greater amongst people living with or people who use and inject drugs. And here is a meta-analysis, again, looking at the difficulties of retaining people, ensuring that they are virally suppressed, and thereby increasing their outcomes or improving their outcomes is difficult in this population. Triple therapy has improved greatly over 30 years, and we now are able to offer a pill a day as in a single drug that has far fewer side effects, but we know that taking a pill a day can be very difficult, and really in all populations there is this revolving door of HIV where we can intervene through things such as multi-month dispensing, welcoming people back into care, tracing them when they lost to care, but there's no doubt that one way to ensure that we retain people in care is to go beyond just the biomedical and to care about this individual as a person. And we refer to this as differentiated service delivery. So shifting from daily to longer-acting regimens is another way of dealing with the problem. And of course, we do start to see this simplification of treatment, even in other guidance, that we can move from triple therapy to 2-drug therapy. And with this has been the entry point of long-acting injectable antiretrovirals. And these are all the trials that led to the licensure of long-acting cabotegravir, an instagrase inhibitor, and rilpivirine, a non-nucleoside reverse transcriptase inhibitor, which can be given either monthly or 2-monthly. There are risk factors with virological failure, and you can see some of them listed here. A mixture of the kind of clade that you may be infected with. There's also been highlighted the possibility of a high BMI, and of course the worry about background resistance being a problem, as well as high viral load at the time of starting. But these are the initiation and continuation schedules for the use of rilpivirine, and you can see again the recommendations are that that it is given by a trained individual. It's a gluteal intramuscular injection, quite large volume of these 2 separate injections, and for this reason, it is we feel it has somewhat re-medicalized antiretroviral treatment in that people have been driven back into clinic settings. And these are some of the downsides, if you like, that have been highlighted in challenges for injectables, that people now, have to come back either monthly or 2 monthly in settings where they might have been offered multi-month dispensing, there is this re-medicalization, if you like, that we have to worry about. In our part of the world, there's high usage of non-nucleoside reverse transcriptase in our history, and this is a worrying factor in the use of rilpivirine. So the guidelines that have come out are quite constrained, suggesting that people have to be virally suppressed. We need to know their genotypes before starting, and they really should be not viremic at the time of starting. Happy to say that in this part of the world, we have shown very effectively that genotyping is not required. So even in the setting of high NNRTI RAMs, we think we have a background of about 10% NNRTI RAMs in our circulating virus. CARES, which was run in a number of countries, including Uganda, showed that, and these are the baseline characteristics, although the patients had to be virally suppressed. As I say, we did not genotype them at the beginning, and very pleasing results at 48 weeks showing non-inferior viral suppression amongst the injectable arm versus background usual drugs. I have seen the 96-week data now, and this is continued as a theme. WHO has now stepped in to support that rilpivirine can be used in these settings, and I think this is going to be important. But again, the requirement here to be virally suppressed. And so there are a group of studies now, small number of studies coming out to say, is it possible for us to do this in the setting of non-viral suppression? And here you see Latitude, in fact, being stopped by the DSMB, showing benefit for individuals, particularly in the secondary endpoints, although although they started virally suppressed, they were not efficient pill users, so they were incentivized to become virally suppressed in order to go into this study. So that was very pleasing. Monica Gandhi in San Francisco has shown in Ward 86 again good usage of the injectables in settings of people who may struggle to be virally suppressed. And here is a group of studies with details of in the real world, as well as sort of implementation science of people who were not virally suppressed and doing well on injectables. So the guidelines have now relaxed somewhat to say that where there is a risk-benefit ratio that people would benefit from going on to injectables, this may actually be used with caution, but of course remembering hepatitis B. There is no doubt that long-acting CAB with LEN may be a better option, and I'm pleased to say that an ACTG trial is just getting underway. Treatment as prevention is a concept, and I am intrigued just to show you this study, a modeling study now published some time ago, looking at the Vancouver city data, and again making the sort of pronouncement that probably most of the benefit in the Vancouver setting was due to harm reduction rather than antiretrovirals, but we have no reason not to believe that somebody who is virally suppressed is non-infectious in terms of injection drug use as well. So primary prevention, turning there very quickly, of course, harm reduction again is key. I do want to say PrEP sits now within a broad array of different kinds of prevention options, so we can really say, regardless of what population we're dealing with, we have an array, a package of prevention we can put together so that people can choose a prevention package that suits them better. The big question some years ago now was, can a pill a day prevent HIV? And of course, we do know that oral FTDF or oral FTAF is highly effective in all kinds of populations, including people who use and inject drugs. The study that underlined that for us was the Bangkok study now very long ago, but showing that when adherence was high, HIV protection was similarly consistent and high. What we know, though, is not everybody can take a pill a day. Some do, but some struggle with this. And again, there is plenty of data, qualitative and otherwise, looking at how the PrEP care cascade falls down in the setting of people who use and inject drugs, and they're not the only population that struggle. We struggle a great deal with young adolescent girls and young women in this part of the world also, with the daily pill taking. And again, people have qualitatively gathered this data. It's a mixture of stigma as well as just lifestyle and difficulties. Happily, the PrEP world is also expanding in terms of innovation. There are now a number of different drug targets that have been targeted for pre-exposure prophylaxis, and we have an amazing array of antiretroviral-based prevention now available to us, both short-acting, as you see, all the way through now to long-acting. The dapivirine vaginal ring I won't cover today, but we do know that we have long-acting CAB, we have long-acting LEN, and in the works is a monthly oral pill and 12-monthly LEN on its way. Here is CAB-LA, 2-monthly injection with a loading dose at month 1, and happy to say that this is also being explored as a 4-monthly intramuscular injection. ViiV is completing the bioequivalent studies as we speak. Although PWID have not been included in the populations until just recently, there is no reason not to believe that long-acting PrEP will be very useful in this population, and certainly there does appear to be in early studies, acceptability studies, a lot of support amongst this population for long-acting options, particularly those who have lots of stigma issues or other, social status difficulties. In our hands, when we've offered CAB-LA, and this is in an implementation study, we have seen up to 3/4 of people choose CAB-LA over oral PrEP. And the reasons are convenience, discretion, a number of different reasons. We see better persistence in the setting of 2-monthly CAB-LA. We see that particular personalities prefer this, and I will say that we are using our RDT rapid testing in order to initiate people on CAB here very successfully and safely. Unfortunately, the rollout, particularly of these innovations, have been rather sad around the world. There's been a mixture of cost and lack of access, and so there is a lot of work to be done in this regard. We stand at the dawn of the lenacapavir PrEP rollout, and here you see very exciting results that I had the pleasure of showing the Purpose 1 studies in Munich last year, an incredible 100% efficacy in the women that have sex with men study, 96% shown in Purpose 2. This is an intriguing slide that Sunil Solomon sent me to just remind us that we too often leave these populations out of our clinical trials, and more than 200 people in PWID went down with HIV whilst those 2 trials were being run in this part of the world in South Africa. So just a plug for including these populations in these trials. Lenacapavir's mode of action is as a capsid inhibitor. It is multi-stage. It works in a number of different ways. It has a relatively low resistance barrier, but of course highly effective, and with this long-acting good half-life, it does mean that we can offer it 6 monthly as a subcutaneous injection. So you see, you take 2 injections on the day you start, 2 300 milligram tablets to load on day 1 and day 2, and this needs to be given subcutaneously. You can't take all 4 tablets. I get asked this all the time. On day 1, they have to be taken 12 hours apart, as you see, and the benefit of doing the loading dose is you are immediately protected by day 2 with the protective drug levels. Of course, there's always downsides with an injection, and that is the injection site reactions. We also create a little nodule when we inject subcutaneously. Here you see an example in a thin person. Happily, in our more endowed subcutaneously woman, we don't see the nodules, we can feel them, and pain happily seems to decrease over time. We did see 2 breakthrough infections, as I mentioned, in Purpose 2, and you will see that they both resulted in resistance mutations. So that is something to watch. I will just say that lenacapavir dosing does have drug-drug interactions. It is a CYP3A substrate, so one has to be careful in the setting of TB drugs. Modeling studies have shown that we can supplement with more injectables and more pills in order to get through that problem. It is also a mild inhibitor of CYP3A, so we have to be a bit careful with drugs such as impotence-treating drugs, statins, and there is a question around fentanyl and other substances that have to be worried about. Happily, we are seeing further development for LEN, and this is Purpose 4. It is currently being conducted in the US to see lenacapavir acceptability and uptake in the setting of PWID, and you see the eligibility criteria there. These are the study sites. It is enrolling currently, and we look forward to seeing those results. So an incredible array of people, including pregnant and adolescents, have been tested. The FDA has approved lenacapavir now in a number of different populations. This is what licensure looks like, and this has also been offered by Gilead Sciences to 6 generic companies. The wonderful announcement last week that Andrew Hill's $40 per year has actually been matched by 2 generic companies, saying that when they come through, they will charge $40 per year. Happily, also, there will be more development here with an annual lenacapavir injection. And then my last word, and I know I'm really wrapping up, is around integrated care. So I do want to make a case that the best way to provide prevention and HIV treatment is in a single window kind of approach. You've heard lots about this. There's innovation in how we do this, and ways that we can enhance people's engagement, make sure that they stay in care, and therefore have better outcomes. So I'm giving a shout out to Sunil Solomon's Blue Shed in India, but reminding people that whilst HIV is very important, there are many reasons why people have poor outcomes, and this really requires us to have these innovated, integrated, consistent supplies of care. Finances for the HIV response are under huge threat, as you all know, with 22 countries relying heavily on donor funding for prevention. Now that USAID has gone into Elon Musk's wood chipper, we really are very concerned about PrEP. And you see that prevention treatment in this part of the world, particularly for PWID, is under huge threat. And so I do want to shout out for community, which has supported us throughout this epidemic. We cannot find the end of AIDS without the community, and of course that needs funding. So I do want to just say that we cannot leave anybody behind. There is work to be done in this regard. It needs all of our activism again, I'm afraid. It takes us back to 2000 in that regard. And I will just acknowledge that it's wonderful to be part of this and to know that we are working together to make sure that nobody is left behind.